Hi, everybody. My name is Dr. Brian Clifford. I'm a physical therapist by trade, a primary spine practitioner by practice. Thank you very much to John, Murph, David for the opportunity to hang out and chat for a little bit. I won't go into a crazy amount of clinical details, but try to provide the overview and kind of, as part of also the intro to me, intro the program. Kind of will work to kind of go through both at the same time, might be a little bit more advantageous. If we can go to the next slide. So that's myself on the left. I've been part of the integrated spine program for roughly a little over 7 years. Dr. Lisa Manning joined us shortly after, about a year after that. Dr. Manning, myself, we are the two primary spine practitioners currently working for Atrius Health in the integrated spine program. A little over a year ago, Dr. Joshua Lee joined us. He's a doctor of physical therapy and has been kind of a PSP in training and helping us to act as a primary spine practitioner to the best of his ability as he continues to kind of work and hone in on his skills with us. A little bit about the program and our foundings. If we can go to the next slide. So just a general overview of Atrius Health. Atrius Health is a large outpatient practice consisting of roughly 30 outpatient facilities around Eastern Massachusetts, as far south as Plymouth, and extending into the Cape as far north as Peabody, Beverly area, if you know the Massachusetts region at all. Primarily internal medicine and medical specialties, but also surgical and ancillary specialties. I think there's roughly 8 to 10 physical therapy clinics. There are some chiropractors that are affiliated with Atrius Health. There's roughly, I believe, 800 to 850,000 patient lives are within the Atrius umbrella. The integrated spine program was originally developed as a concept for us, kind of presented to us by Dr. Cameron Brown. Kind of our original primary spine practitioner. I had the pleasure of working with Cameron, learning from him for roughly 4 or 5 years. And it grew from roughly 2016 to 2017 into 18. We started, it was just Cameron. I was the first one to kind of jump on board with him in this general concept. Don Duger, an administrative phenom, is no longer working at Atrius for a few years now, but he is still a member of kind of that founding team. And the original kind of core mission and value was to partner with our internal medicine colleagues at the Harvard Vanguard, the old Harvard Vanguard Medical Associates, now the larger Atrius Health, in our Cambridge, Massachusetts location, to act as a primary spine practitioner and essentially offload the internal medicine teams of spine-related disorders. Next slide. So during that time, this slide's incredibly busy, but this kind of is a snapshot of the work that was done preceding our ability to really form this program. In 2015 and into early 2016, there was a series of meetings with our chief of pain medicine, who is also oversees our spine program, one of our spine interventionalists, physiatrists, myself, Dr. Brown, and administrative leads, and we would smash our heads together in a room once every few weeks to really look at, with the foundations of the CRISP protocols and also pulling from the TBC and other clinical resources, what is this going to look like in real practice in Atrius Health, and how can we reform spine care in an algorithmic way with guidelines and resources to guide us in that goal. And this is essentially the algorithm that we developed over that time, which takes into account primarily the CRISP protocols and the top 2/3, that middle sliver looking at biological perpetuating factors, namely myofascial dysfunction and dynamic instability, where at the time that would have been the chief role of the physical therapist embedded within this program and integrated practice unit. But also having resources to screen out and look at other psychosocial perpetuating factors, namely using the Kiel triage tool And I'll kind of walk you guys through the history of how that evolved for us. And the next slide kind of starts that process. Oh, sorry, it gave you the actual full slide. So you may need to click through a few times for all of the pieces. So we'll kind of go to the point where this kind of shows the big picture overview of this. You can keep going through a few more clicks, David. If you have to scroll back one, that's fine. So this is essentially what the care pathway looked like. So here we had multiple entry points into the integrated spine program. So most of our patients are referred to us through internal medicine. We did have goals years back to try to create a nurse triage call center, which funny enough, with COVID and telehealth, we ended up becoming the virtual triage center. And it's been really a fantastic program and ability for us to reach patients more effectively, efficiently, and also more broadly over the geographic area of Atrius. And through the keel triage tool, any patients that had measured through the keel as medium or high risk would then come straight to us, an integrated primary spine expert. And from there, we would use the CRISP protocols and a dedicated physical therapist, which was my initial role, to help to quarterback spine care for these folks. And from there, we were able to really guide the patient through the continuum of care. We can tee up necessary imaging regarding X-rays when appropriate, more appropriately MRIs. Most common referral pathways are to our spine pain clinic to discuss ESIs, facet injections, branch blocks, whatever may be most appropriate. Also to coordinate care with orthopedics if it's another etiology masking a spine. For those folks that do need it, we can also coordinate with our surgical team. From a spine program perspective, we have 3 full-time interventionalists that do spine-specific injections, and there are 2 spine surgeons. And currently, we are working to build that clinical team. We have been working to also build the integrated spine component of that, the conservative care triage arm. And we've had our hiccups and challenges, which we'll chat a little bit more about later. The other portion of this slide are the proms in the top right corner, namely the keel and some of the patient-reported measures, Likert scales, specific functional disability questionnaires, and the Oswestry. This is something that we set from the beginning, knowing we wanted to measure proms on a long-term scale. So patients, we were able to work with our Epic vendor and build into Epic an automatic queue for these patients. So essentially, they get these sets of questionnaires at initial evaluation, 30, 60, 90 days, and 1 year. And we'll talk about, hopeful projects moving forward to digest all of that information that we've collected over the past 8 years. If we can go to the next slide. Over time, this ideal state of spine care for us has morphed and consolidated to a degree. If we can go to that next one, David. Perfect. Thank you. So we've kind of reeled this in a little bit. The keel triage tool for us, it was originally being given at an internal medicine visit. So if a patient with any spine-related complaint presented to internal medicine, they would then get a keel triage tool by our medical assistants, and if they scored medium to high, would be sent to us. All of the steps involved in that presented a barrier to care. It was actually more clicks, more people in the mix, and it was harder to get patients to us. So we would do educational rounds with our internal medicine doctors, and what it kind of boiled to was, if you're getting the sense that they're not actively handling their symptoms well, please send them our way. We are happy to help. For folks that seem to be active copers, no clear psychosocial variables involved in their symptoms, seem to be handling things well, usual care to start, but we can always revisit that in the future. But from there, once into the integrated primary spine care program, they were with us. We then quarterback their care from then moving forward, as was mentioned in the last slide, through CRISP protocols, the TBC, using that as a foundation, and then coordinating care with higher level spine care providers if and when appropriate. If we can go to the next slide. So the next slide and a couple of the others moving forward, I'm not necessarily going to speak to each point on for everyone in this group. I'm assuming you know it, but just as we developed this and looked to move this forward, there was a lot of education that had to happen. It was really important for us to collaborate with our internal medicine providers, provide as much education as possible, really explain what we are, what we're doing, what our goals are. And it was a big cultural shift. When we started with one internal medicine team, our relationships with those providers were phenomenal. I believe I was in Cambridge for 3 years. And it was I think we were just really lucky to have such a great group of internal medicine providers that were also had a lot of good job satisfaction otherwise in their roles. Many of those providers are still practicing at that site. There has not been a ton of turnover. We still see patients from those folks today. And for that reason, I think it was really a great fit to help us get this going. But these are a few of the things that we kind of pitched in terms of taking over that role for them so that they did not have to coordinate all of that care. And help to kind of guide the patient and not just allow for continued handoffs where patients end up having the sensation that they're kind of passing the buck. If we can go to the next slide, David. So part of our pitch, along with kind of what we can do for them, was also, what's in it for the patient. And these are some of the goals that we had presented to the internal medicine providers. Again, it was a primary care initiative. Our IM teams loved the idea of a primary spine practitioner being a quarterback for this. The supermarket approach, as per Dr. Haldeman, was a major issue and concern for many of our internal medicine providers, and they were happy that we can kind of go shopping for them and clear a lot of that up. Virtually, we'll talk about that a little bit more in a moment. The other piece that our internal medicine docs really loved and continue to appreciate is we are engaging in active treatment on day one. Oftentimes, in my anecdotal experience, a patient dissatisfaction component is, I saw this person for 10 minutes, they took me through some tests, now what do I do? And that has been a major kind of selling point for us is we're going to get them engaged in treatment day one. This is where virtual care was really phenomenal because you cannot passively treat patients virtually. They have to be engaged, they have to be enthused, they have to be motivated. And for the most part, folks were. And folks who may not have been otherwise, especially during COVID, they didn't have a choice. They had to be engaged. And we had really great anecdotal success. And there are a few things, as I say that come to mind that I would love to eventually digest, but I'll go through that a little bit more in a couple of slides. But with the information that we have been collecting and that we can retrospectively analyze, I think we can really eventually compare how good are we at doing this in person versus virtually, and also look at the kind of cost benefit and total medical expense analysis with that as well. As primary spine providers, we also do provide all of the other aspects of chiropractic care and physical therapy regarding instrument-assisted soft tissue work, spinal manipulative therapies. Part of that, in the previous slide, it showed kind of all of the potential providers that can fit into this role. And per Michael Schneider, if you have the knowledge, skills, and training, you can do this job. And that's where we had a great relationship. Our team at its peak was 5 clinicians, 2 chiropractors, 3 physical therapists, and we all treated the same way. There was no big dramatic differences. We all had our clinical niches where we felt we had a little bit more comfort and expertise. But at any point, any one of us could step into a room with a patient, be able to thoroughly evaluate and treat, and we all were speaking the same language. And that continuity was really huge for the early success of the program. Regardless if we were doing interdisciplinary care coordination or counseling with patients, education of family, it was a consistent message, and that really helped us to create a good culture around what we were trying to establish and push forward. If we can go to the next slide. So for the referring providers, the internal medicine docs, as well as the other specialties that referred to us, outside of the patient experience and their care, was that there's really no single point or entry or way to get into us. We actually had one hurdle we had as we kind of consolidated and our program morphed and evolved to be more integrated with interventional and surgical spine colleagues, was how do we clarify this pathway? I don't want to speak to other settings, but I know in ours at one point, if an internal medicine provider had a patient with quote unquote non-specific low back pain, who do you refer to, kind of thinking about the supermarket approach? Well, there was kind of a supermarket referral pathway. And we had referrals to spine program, to spine surgery, to physiatry, to some internal medicine docs were able to find referrals directly for injections, even if those folks may not have necessarily been appropriate to go right into getting an injection. So there was roughly, I think at the end of the day, about 15 referral pathways. And we tried to consolidate that into a single point of entry into us, where we now have a single referral module. There are still pieces of this that we're looking to kind of clean up and fix. But what that does is it kind of funnels and forces patients into that algorithm in the most appropriate way, so that we are able to identify patients' needs. We're able to get those patients to the right clinician at the right time and expedite their care as efficiently as possible. And that was a huge piece for the referring providers. Apologies for the background noise. That was a huge piece for the referring providers, because we took the supermarket not just in terms of what treatment should a patient be looking for, but what other provider should a patient be looking for. And as part of that, we actually evolved to a place where, for folks with established relationships who have had ESIs or facet injections in the past, who saw success, we're trying to get those patients right back to that interventionalist. Let's get back into that clinician's office where you had success, the treatment had worked, for some reason the pain returned, but we can then also follow up with them to reestablish conservative care, make sure that what they're doing is what has been recommended, and help to kind of tweak and change things as necessary. If we can go to the next slide. In the patient experience, and we lay this out pretty clearly for folks from the get-go. From day one, the evaluation is in depth. Our clinicians spend an hour or more with our initial evaluations. We go through a full red flag neurologic screen, special testing, all via CRISP protocols and guided by the TBC. The virtual care component to this, our goals still, because we had fantastic, even business success when we were fully virtual, was to be able to virtually triage, thinking back to that ideal spine care pathway. As primary spine practitioners, we have been able to virtually triage patients, many of whom we can initiate active coping care pathways by virtual means and provide them resources through data encrypted messaging pathways where they can start to be involved on day one in their care. And we've had a lot of success doing it. And treatment starts right away for those folks with concerns. If they are demonstrating an inability to heel or toe walk on a video call, what that allows us to do is actually get them into the clinic sooner. We can make that in-person consult happen faster. The virtual care pathway also allowed us to really broaden our geographic outreach. So where we were in Atrius Health, we call the urban region, which consists of 3 to 4 facilities in the greater Boston area. We've been able to reach into the river region north of Boston and the western region in the western suburbs of Boston. So we've been able to really geographically have a much bigger impact. Imaging, we do take a lot of time with patients explaining what image and why. And that is not always really our internal medicine providers and other specialty providers, that it takes time to explain that. And we are able to do that. And a lot of times we're able to kind of quell the concerns on unnecessary imaging. We are actually currently in a project to evaluate that further, which we'll chat about. Our chief limiting factor, limiting in one sense, I think better in many others, is that we are non-prescribers. Currently, all of our 3 clinicians are doctors of physical therapy. We cannot prescribe, but we've had fantastic relationships with our primary care providers. So when there has been circumstances where pharmaceutical management may be a good option, but interventional and/or pain management providers may be harder to get to, we do have robust conversations with our internal medicine teams. Next slide. I'll try not to spend too much more time, so there's plenty of time for questions. For us, we have loads of opportunities for continued growth. There's always the ability for administrative process improvement. A lot of our business end of things, I do defer to our business folks from a billing and insurance side of things. And there's a lot of continued discussion and collaboration, checking on reimbursement and things to that effect. Recently, Atrius Health has become a part of the larger Optum Care umbrella, which has been fantastic. And with them, as well as internally, we're always looking to improve care pathways for our patients. A barrier, and I say that loosely, because it's not really a barrier, it's kind of part of the gig, but a challenge is continued education for our internal medicine providers and all of our referring providers, because this is new, this is entrepreneurial, this is not something they may necessarily have heard of coming out of school. So in those circumstances, to put us out there, to make sure we are having clear, concise communication with those providers, explaining what we do and who we are and our backgrounds, is really important, not just so they know who we are and who to refer to, but also to build that confidence and comfort in referring to us and really allowing us to take care in that patient care pathway. And another challenge, and one that I've experienced over the past few years and have kind of toyed with in a few different ways, and lots of discussions with lots of folks, is recruitment. And I'm excited to be a part of talks like this. Again, thanks to John, Murph, and Dave for helping and allowing me to be here. Because recruitment is key. We need more PSPs in the world, and we need folks ready to take on these challenges, because as someone who's been doing it for 8 years, it's not easy. It's not general outpatient orthopedics. It's a very different role. But one that's important and has been hugely gratifying, and I've really enjoyed over my time doing it. If we can go to the next slide. Kind of as I'm enjoying my clinical time, we're also trying to kind of dabble in other ideas. I mentioned proms and other aspects of value-driven care. Currently, I'm undergoing a couple of projects with our academic institute within Atrius Health. Keeping my fingers crossed, this parlays into bigger projects also with Optum. And I know Optum has done similar projects in the past. David Elton, I think, published some work regarding chiropractors as primary access points for spine care and the benefit that provided. So we have been collecting proms for 8 years on some folks. We have the ability to retrospectively analyze imaging and medication rates. and which we're hoping is going to really show huge benefit in terms of TME and overall cost. Challenges in that assessment and idea really stem from Atrius has an interesting kind of financial model right now where it's nearly, and please don't quote me on the numbers, but it's almost a 50-50 split in terms of capitated patients and fee-for-service patients. So what creates value on one end of the fuse actually decreases revenue on the other. So it is a definite tug-of-war situation that we continue to navigate and learn from. But I do think that with our recent kind of collaboration, if that's the right word to use, with Optum is going to really help to kind of shed some more light and clarity and consistency in terms of the business side of things in that regard. We've had some success with expansion. We've grown to as many as 3 facilities. We are now currently in 1 facility. We've grown. We've lost clinicians. We've grown again. We recently just lost one of our original primary spine practitioners, Dr. Natalie Briggs. Just moved closer to home. I'm still a little heartbroken, but so expansion and retraction and trying to build consistency while navigating those changes is always a challenge, but we have seen some intermittent successes. One of the successes I'm most proud of over the past 8 years is the clinical collaboration. And this is one of the things that kind of drove me to this program is you are a part of the medical team. You are not just a physical therapist that is sent to by somebody and then that physical therapist sends back to the medical team so everyone can do the medical workup and the PT is on the fringes just watching this from the sidelines. This is really what drove me into this, is to be a dynamic, active member of the healthcare team throughout the continuum of care. And that's been kind of one of the more gratifying parts of this. Our alignment with internal medicine in more recent years, more aggressively with our interventional colleagues, communication, collaboration with our surgical colleagues. As a physical therapist of 15 years in my 5-6 years prior stepping into, more than that, 7-8 years prior to stepping into this role, didn't really exist in that sense. And I think it does for some clinicians in some circumstances, and those are definitely your top performers that are working hard to create those relationships. They're hard to create. We worked really hard to create them, and I'm definitely very proud of what we've done to continue those and build on those. And it's kind of a never-ending part of the role is cultivating, maintaining, and building on those relationships. So that was all I had. If you want to hit the last slide, David, or open it up. Again, appreciate everybody's time and listening to me rant and ramble. I'm happy to take any questions and chat some more.
We experienced technical difficulties in the following Q&A of the webinar. If you are listening to the audio of this recording, kindly note that the questions are displayed in text on the screen. You will need to watch the video to read the questions. Thank you for your patience.
We are all full-time employed by Atrius. We are our 2 PSPs and Dr. Lee. We are all full-time employed as physical therapists. We are, and kind of from the HR side of things, clinical specialists, which gives us the kind of HR designation of our role. But kind of to that, and just in my head as I'm thinking and saying that, yeah, I would love to see a primary spine practitioner role. And I would love to see that on HR's books as something to hire into. I think it's going to be important to get there. We're not there yet. Even 8 years in, we're not there yet. I think that's we've been doing so much and been so focused on the clinical side that hasn't really taken front and center in terms of our efforts. But yeah, the question makes me think that's a project that needs to happen next. We are, so myself, Lisa, Dr. Briggs, and along with Dr. Brown, we were at UPMC for a couple long weekends a few years back. I think it was 2018, 2019, might have been just before the pandemic. That first cohort that came through. What is such a wonderful group of individuals running that. Professor Timko, Murph, Michael, and everyone who, without going through all the names, the whole list of everyone on the TBC. It was honestly a kind of like a starstruck time in my life, hanging out in rooms with those folks and chatting spine for a couple of long weekends. I loved it. I love that question. Yeah, how do we make that happen? So I think the most important thing that got this off the ground was and I want to say the phrase right, but the first two words that pop in my head is an administrative superstar. You need an administrative lead who is tied into the socio-political influences within the company, is ready to take that chance. And I think that combination early on, even prior to me kind of coming on as a member of the team, when Cameron Brown and Don Duger took the time to lay the foundations for this, Don's work and efforts in garnering support for giving this a shot is in my opinion, the only reason why this took off to begin with. There was a lot of doubt, a lot of suspect, as there always is with something new and entrepreneurial. So I would give Don Duger probably 51% of that credit and Cameron 49. Clinically, Cameron Brown gets like 99. But Don was huge. To have that administrative support and backing was absolutely enormous. So if you find that administrative role player that has that, and you can have those conversations and kind of put out your business plan and proposal and clinical plan and proposal, that would be the first person I would want to seek out to assist. I don't offhand, and it unfortunately is really small. It's not nearly what we want. The Atrius health system is big. There are a lot of patients. Even when we see spine program referrals and our ideal care pathway, no imaging, they're seeing us first. If there's geographic requests, if there are requests to not be seen virtually despite those geographic limitations, those patients are then being seen by PAs and Ps who, yes, can diagnose and triage spine-related pain, but they're not functioning in the full PSP role. So they're not missing care per se, but they're not getting primary spine provider care. And I will be, maybe the right word is cocky in saying, I think we're better. I think we can offer more. I think we can do more. And so, yeah, that is kind of a sad part of the gig so far. There's a whole lot of people that we can be helping. One of our chief limitations in recruitment is just that there's only 3 of us, and Atrius has 850,000 patient lives under its umbrella. So we are only seeing a small fraction. And that said, when our administrative processes are on point, we're jammed. We are being utilized. That's a whole. There's ups and downs on that. That's a whole other conversation. But yeah, it's small. There's definitely room for expansion and building. The machine is kind of running. We just need to continue to make it bigger. Our relationships were phenomenal. Cameron was a close friend of mine for a good few years there, and we were tight and we were on the same page. His background, he had a lot of powerlifting and a lot of McGill end of the spectrum biomechanically behind him, which I gravitated towards. That's my kind of background and thought process as well. Cervical manipulations. I'm still not crazy comfortable with. It's just not in my wheelhouse, and I know that. It's kind of, the smartest people in the world know what they don't know. Well, I know I'm not great at cervical manipulation. So it was awesome when we had that, Dr. Christina Ippolito, who was phenomenal in her manual skills. If I was like, listen, Christina, this really looks like a cervical facet issue. Do you mind hopping in for a minute? Give me your thoughts, and if appropriate, can you do a manipulation? And she'd be happy to help. So we had an awesome collaborative effort in that regard. I do miss it. I would like to see us go back to that. There are financial implications in hiring and reimbursement and all those things, which over the time where it's been just PTs has been easy because it's just PTs. I think at one point, I would love to have to navigate that again and find the right DC to be a member of the team. We'll see where it goes. We're always recruiting. We're always trying to explore and expand, even as we tackle the administrative pieces. But on the whole, I think the communication between DCs and PTs was spot on. We've never had any headbutting, any of the stereotypical DCs versus PTs. We never saw that. Our internal medicine providers who are referring are all under our same Atrius umbrella. So it's all really in-house for the most part. There's definitely small percentages elsewhere, but for the most part, it's in-house. The probably top 3 conversations I've had with referring providers is one, well, you're a PT and they've done PT, so why am I referring to you? And that's usually where I have to really go through that, some of those earlier slides of, no, here's who I am and what I do. And this is not regular PT. And I have all sorts of soapboxes I could jump on that. So we're not that. But once I clarify, it's usually a great relationship and doctors get it. More so, once they have an experience with a patient that they referred and they see that patient later on, it's validating. It's rare that a patient goes back, I'm never seeing that Brian guy again. It's our patient satisfaction is typically pretty high. So that's one point, which is really an educational piece. The other is the medication piece. Sometimes our internal medicine docs may not be comfortable with navigating the pharmaceutical options for a given pain complaint, and they're referring to the spine program to help to manage that. Lots of challenges with pharmaceuticals, obviously, the obvious ones with narcotics and opiates and what that can lead to. Debates on whether or not oral steroids are appropriate, inappropriate, and where they lay in clinical practice guidelines. So it is a hard thing to navigate. Our challenge has been, if a patient comes in without any imaging and they would benefit from conservative care options, but their pain is not being well managed, to get that patient in to see an interventionalist and or a pain management specialist, value starts to plummet. There's always going to be an access issue with those clinicians because they are in high demand. And we're missing that active coping piece off the bat. We're automatically hopping over that into passive coping with pharmaceutical management. More ideally is having those established relationships with primary care providers to say, here are the options that have actually been delineated through educational materials by our pain management program that may help your patient. So we're not always necessarily making specific medication recommendations, but we are providing resources to say, here's what the clinical practice guidelines say. Here are potential options for this patient. Decision is totally yours, not ours, and we're not trying to steer you towards one. But if we're waiting for pharmaceutical management to get to an MD, that's a harder referral pattern. It's harder to get to that interventionalist. From a value care perspective as well, if that patient bypasses us, goes right to the interventionalist, typically imaging is necessary to have a robust clinical discussion with that clinician. And if a short course of prescription NSAIDs may have done the trick, they may now be going in for an ESI. Well, where's the value now? The value is really plummeting. And even after that ESI, how are they going to do if they haven't identified the biomechanical variables surrounding their complaint? So those are the backs and forths we typically have with our internal medicine providers. I would say medication management is probably the biggest sticking point. The last one is access. 850K folks and just us, it can be tough. That said, I tell all of my internal medicine chiefs, all of our internal medicine chiefs, message me directly. We will make it happen. We get patients in. Great question. So the short answer is yes, but it's not as structured as that. I would love to see it get to that place. Even with our interventional colleagues and that the interventional and surgical level programs, I'm actually currently working with colleagues kind of, not across the aisle, because no aisle splitting us. It's kind of across the company in Optum to establish similar pathways. They actually have similar care pathways for OA care that we are having a lot of discussions, and we actually introduced our programs to one another a few weeks back, which was awesome. Kind of like a kid in a candy shop, just more people chatting, ortho spine. With internal medicine, it's typically me. I usually every few months pick an internal medicine team, either because I haven't seen them for a while, or we're seeing that outside utilization and outside referrals for spine care are ramping up. So that's when I try to come in and circle back around and say, hey, we're here. I know it can be hard sometimes, but we're still a resource. And we'll go through clinical scenarios that they have questions and concerns about, and kind of give them an overview of the program. IM turnover is a major role player in that too, because if IM docs come and go, you have new doctors coming in who've never heard about us, and they don't know what it is we do. So to have that kind of continued education and collaboration is key. Some of the chiefs who have been around for a long time are probably sick of seeing me, but the new docs are always like, wow, this is really cool. It's a nice resource to have, and it's usually positive vibes as we part ways after those meetings. So yes, and that's kind of the continued refreshing piece for us as we continue to move forward. I business acumen in that sense is not my strength. That's not where I do well. And there's a whole business side of Atrius that handles a ton of that. Where I continue to kind of, when we have discussions on utilization and access and resources, my first pitch to our administrators, our business folks, and our other clinical colleagues is purely clinical. Everything I try to discuss is clinical. And my contention is yours. And when I have those conversations with folks, as that has evolved from Don's fantastic work, and another reason why a guy like Don is so important to have on your side, because he got it from the get-go, that it was clinical, but over time, with TME and retrospective analyses and making every clinician on that care pathway practice at the top of scope of license, the financials will fall in place. That will only improve. A metric I don't have perfectly, but highlights that in our site and facility, where we are directly intertwined with our interventionalists, their interventions per patient is nearly in half to that of other sites. So from a capitated perspective, that's phenomenal. Now, they're still busy. Their schedules are still full. They're still doing lots of epidural steroid injections and facet blocks and all these things. So their fee for service is still there too. The patients are still there, but they're able to see more. They can see a greater N of a patient bank because everyone's operating at max scope of license, and we're still providing a value-driven service that is really kind of taking away unnecessary care from those who may not need it. Cost data, we fortunately can always retrospectively go back on. So we see from a business perspective, you get that monthly packet of here's your financial performance. Again, I don't understand half of it. I'm still learning and working on it. So we can always kind of go back and look at a lot of that. The proms is the big piece that we're starting to initiate bigger discussions on with our data analysts and folks that can help to crunch that data. And essentially what we want to look to be able to do is put our money where our mouth is clinically. How much better are our patients doing? And because there's not a ton. I remember speaking with Brian Justice a while back saying, we want to see how those folks are doing in 10 years time. Not necessarily in 6 weeks where a lot of the data lies. It's the short-term proms collections, and are they better at day 1 versus day 90, or whatever the time frame is. We're almost there. We're closing in on nearly 8 years of proms data, and obviously we have to analyze how many people actually responded, and how many people responded long term, and folks that did return to our program. Where were they at 5 years ago versus this course of care? So a lot of questions to look at there. But the train is moving on the tracks. It's just a really slow train hauling a lot of cargo. It's going to take time to get there. My first push from an analysis standpoint is actually, and I put that Fritz article up on one of those slides because she looked at this in one of their clinical settings. What are we doing for imaging rates? Imaging rates from Center of Medicare. One of our HEDIS goals is low value imaging within 30 days of a initial ICD-10 drop of any orthopedic back pain complaint. So this is something that the company has analyzed for a while. Goals are at less than 14% of those folks are getting imaging. At one point in Cambridge, we were, I think, below 5%. So we were demonstrating we were creating an impact. And that impact is harder where we are at currently in Boston in Kenmore Square, and there's less of us, so it's harder to really truly analyze and appreciate that benefit. But what we're trying to do right now is retrospectively look back, and what I want to do is compare for any folk with any patient, folks with orthopedic back pain complaints that have been seen by a primary spine practitioner versus those ICD-9s and 10s without a primary spine practitioner. Where are those imaging rates and how much money was spent? Is kind of the big question. And one of our surgeons, I had a great email exchange, and he goes, "Wow, that's fantastic. Have you guys crunched this data?" And I said, "No, not yet, but that's the $1 million question." And I'm hoping it adds up to that. We shall see, but that train is moving a little faster. The data analysts, we're actually scheduling a meeting, I'm hoping in the next couple of weeks, to really push and get that retrospective analysis done. No, Atrius does not own any inpatient facilities. They do have strong clinical affiliations with locally Mount Auburn Hospital, clinical affiliations with Beth Israel Deaconess, looser with the MGH Brigham conglomerate that is huge in the area. So no, they do not directly own any inpatient facilities. The locations in which we do those things are ambulatory focused, so a lot less money. There's actually, from the surgical side, is outside the realm of this, but there is a huge push, as there is in general orthopedics, but a much bigger push for more ambulatory surgical center use, which is awesome. They've done a lot of work with hip replacements in that regard, and I've always thrown my hat in the ring to say I would love to collaborate on how we make that happen more consistently in spine, knowing my role and where I sit on that end of the clinical spectrum, but great conversations to be a part of.